Hello, my name is Dr. Rico Short. I'm a diplomate of the American Board of Endodontics and also an assistant clinical professor at the Medical College of Georgia School of Dentistry. Today I'm going to be talking to you about contemporary endodontic treatment, its role in retaining our patient's natural dentition. If there's any questions, comments, or concerns, or you need any additional information, you can email me personally at dr.short@yahoo.com. Disclosure statement. In compliance with the American Academy of Family Physicians AAFP guidelines, I hereby declare I do not have financial or other relationships with the manufacturers of any commercial services discussed in this educational activity. Further disclaimer, the information presented in this presentation is designed for educational purposes only. The reproduction and/or selling this material is unauthorized unless approved by Dr. Rico D. Short and/or the American Association of Endodontists. I can be reached once again at my website here at dr.short@yahoo.com, or you can reach the American Association of Endodontists at www.aae.org. My practice is located in God Country. I call God Country, Smyrna, Georgia, 577 Concord Road, Suite A. Our slogan is getting to the root of your problem, and that's what we try to do for every patient that comes through the door. We can be reached at 678-503-0790. What are our objectives for today? First objective is to figure out how the endodontist fit into the treatment plan for the patient. Recently, with the advent of implants and a lot of general dentists performing root canals, some way, shape, form, or fashion, some of the endodontists in different areas have been kind of cut out of the treatment plan. So I'm going to talk to you guys about some different ways that we can be integrated. In my opinion, if there is any tooth that's questionable, that can be saved or not, I think it's just pertinent to send that patient to your local endodontist, at least for a second opinion. The second objective is predictability of endodontic treatment. How predictable is endodontic treatment? How successful it is? And the third objective is to talk about new treatment paradigms. What are some of the new armamentarium and equipment we're using now to make endodontics more efficient, more predictable, and so on and so forth. Let's jump right into this. I had a referring doctor, had a trauma on a kid on teeth number 8 and 9. She performed endodontic therapy on the teeth, and she said, well, Dr. Short, I have a problem, and I don't know what to do. Can you see the patient? I said, sure, send the patient right over. So this is taking endo a little too far. No pun intended, but she did the root canals, and she actually pushed the gutta percha here out the apex, and this is way out, almost kind of under the patient's nose, so to speak. So we had to really jump in here and try to take care of this particular young man. So what we had to do, we had to retreat number 8 and number 9, because I wasn't sure if she was able to get everything cleaned out properly, and we wanted to make sure that the success rate on this case would be as high as possible. So here's the retreatment on the case. These are some pretty large files here showing my working length where we want to be, and this is the retreatment that we did in one visit. And you see, we have UFO or gutta percha hanging out, and also some sealer material. So we decided to go right in and do an apicoectomy, and we removed the overextended gutta percha. So this is me actually doing the surgery here. If you can look really closely, this is the gutta percha that was actually out into the tissue that we were able to remove for the patient. And this is the apical surgery completed. We were able to clean everything up really nice. We did not have to use any membrane or any bone material in this case, and the patient was happy. We followed him up, and he was able to get these teeth restored, and hopefully he can keep these teeth for a long time. So here it is again, a retreatment and an apical all in one visit. It's the pre-op, retreatment, and the apical all in one visit. One of the main concerns I hear about my referring dentists is say, Dr. Short, I cannot get a good block. I cannot get these patients numb. So I want to spend some time to talk about that. And again, the presentation, what I'm speaking of currently, is kind of like a potpourri of all the different things we have to deal with in endodontics, and hopefully give you some tools and techniques and tips to help you if you're doing endodontics yourself to do a better job, more efficient, and also do these things at a lot more comfortable level for the patient. So let's talk about some common myths of Dr. Short, I cannot get this patient numb. Have you ever heard lip numbness indicates pulpal anesthesia? You know, you ask the patient, hey, do your lip feel numb right here? They say, yeah, and you go in there and the patient just screams like bloody murder, and you're like, wait a minute, I gave you some anesthetic. So lip numbness, sometimes it may not indicate pulpal anesthesia. It may be, the tissue may be numb, but the actual pulp in the tooth may not be. Soft tissue sticks indicate pulpal anesthesia. When I was in dental school, I was taught that, you know, if you numb them up, you take an Endo Explorer, and you poke them, and if they say they don't feel anything, that means they are profoundly numb and it's ready to start working. Sometimes that may not be the case. Thirdly, a lack of accuracy. Some people say, you know, the patient's anatomy, the inferior velar nerve may be to the left, to the right. We didn't get the correct, you know, anatomy. We didn't inject. We might inject into an empty space or some muscle tissue. So we've heard that before, lack of accuracy. Also, incorrect needle bevel. Sometimes they say, hey, you know what, you didn't have the needle bevel correctly, the anesthetic didn't get out properly, so it didn't bathe the nerve to get a very good depth of anesthetic. Accessory nerve innervation. Sometimes, oh yeah, when we give the inferior velar nerve block, you have to give the mylohyoid and some other complementary injections in order to get the depth of anesthetic. And sometimes that can be the case, but not all the time. 2 cartridges are better than 1. Hey, you know what? If that 1 cartridge didn't work, keep giving them more and more. And the concentration of that, and you keep giving more, eventually it'll soak in. You got to be careful with that because you can get something we call local anesthetic toxicity, which can also put the patients in a compromised situation. Articaine is better than lidocaine. This is one of the major things that a lot of the anesthetic drug companies talk about. Septicaine or articaine is better than lidocaine. It all depends, not on all cases, and there have been some studies saying you have to be really careful with the articaine with blocks because you can cause some paresthesia there in some of the patients. So saying all that, according to the latest research, this is the best current reason why you can't get blocked sometimes. It's called the central core theory. Basically, it talks about nerves on the outside of the nerve bundle supply of a molar teeth and nerves on the inside supply incisor teeth. The anesthetic may not diffuse into the nerve trunk to reach all the nerves and produce an adequate block. So we see here, this is a cross section of the inferior velar nerve. We have a mantle bundle that's located here towards the outside, and we have the core bundle. So this is called the central core theory, where the axons in the mantle bundle supply the molar teeth, and those in the core bundle supply the anterior teeth. And the external local anesthetic solution diffuses from the mantle bundle into the core bundle. So it's more or less with the anatomy of the actual nerve bundle itself, and getting the anesthetic to diffuse all the way in to get to that core bundle, which actually causes more profound anesthesia all the way up here to those anterior teeth. These are some proven methods that will help with pulpal anesthesia. A slower inferior velar nerve block, 60 seconds, results in a higher success rate of pulpal anesthesia than a fast one. So when you're giving your anesthetic, you want to try to give it slower than go in there and give it just very fast. Use buccal infiltration of articaine after inferior alveolar nerve block and mandibular first molars. Studies have shown that you can get a more depth of profound anesthesia when you're using this technique after you've gotten the block. So in other words, you can give a block with the regular lidocaine 1 to 100 epi, then you can come back and give articaine, a buccal infiltration, and you'll get a little bit more profound depth of anesthesia. You can use an intraosseous injection after inferior alveolar nerve block to increase the success, whether you just decide to use a Stabodent system or whatever kind of system you want to use. We actually go in through the bone with a perforator. You inject directly into the bone where the roots of the nerves are, or the roots of the teeth are, excuse me. Or you can also give the PDL, which is also considered an intraosseous injection as well. And that's what I just mentioned. You can use a PDL injection after inferior alveolar nerve block in posterior teeth to increase success. A lot of times when you have these hot teeth, that's one of my main, I guess, secrets, if you want to call it. They say they're numb, you're getting ready to get started. You get started and it's like, wow, that hurts. You know, what do? What I usually do, I would get an ultra short needle tip, and I would actually give the intraosseous injection, a PDL, and I'll give it around the four corners of the tooth. And once you do that, you'll be surprised how well. And you have to get some good back pressure. And it's also, and I know this may sound a little crude, but to hear that patient jump and they say, oh, I feel it, that's when you know you're ready to go. Why are hot teeth hard to anesthetize? That's another question I get. Dr. Short, why are these hot teeth hard to anesthetize? These are some reasons here. There's a theory that the pH of inflamed tissue reduces the amount of base form of anesthetic to penetrate the nerve membrane. Also, inflamed nerve tissue has altered resting potentials and decreased excitability thresholds. Therefore, local anesthetic don't prevent impulse transmission due to a lower excitability threshold. The TTXR, or tetrodotoxin resistant class of sodium channels, have been shown to be resistant to local anesthetic as well. And patients in pain are often apprehensive, which lowers their pain threshold. So these are some ways that you can kind of help yourself, help the patient get profound anesthetic by using some of those techniques I talked about. So let's jump into a different topic, standard of care. We hear that all the way. What is the standard of care? How am I supposed to do my root canals compared to the current or local endodontist, or am I held at that same level of standard? So let's talk a little bit about the standard of care. The definition of the standard of care was best stated in litigation case, Blair versus Eblin. And basically they said a dentist is under a duty to use that degree of care and skill which is expected of a reasonable, competent dentist acting in the same or similar circumstances. The locality rule or community standard states that the dentist will be held to the same level of treatment that other dentists are providing in their local communities. This includes proper referral to another dentist or physician when the level of care that the patient is entitled to is beyond the dentist's capability. So in other words, if you have a situation or case that you look at it and you're like, you know what, doing a root canal on this third molar, I don't even know where to start. But you have an endodontist down the street or maybe in another city, you can ask a patient to go over there. But instead of you doing that, you try it yourself and it doesn't work out. In that case, you will be breaching the standard of care because you have the ability to be able to send the patient over, or at least give them the option, versus you jumping in there head over heels and you're not competent and you don't have enough experience to handle some of these tough cases, and that can also get you in trouble with your state or local board. Did you know this? Did you know there are up to 40 million endodontic cases are treated annually? 40 million. That's a lot of root canals, people. And about 70%, in fact the number is up now, about 75% now are performed by you, the general dentist. So let's jump into another case here. This shows up in your office, tooth number 19. The patient is in pain, it's swollen, there's no crown, and you can also see there's a buccal sinus tract here present. So what would you do if you just jump in there? First of all, hopefully you would take an x-ray as well. So we look at this x-ray and we see the previous endodontic treatment was performed with silver points. Maybe some of you guys who are listening to this lecture are familiar with silver points. If you are younger, one of the new dentists out there, you probably never even heard of silver points. But at one time, silver points was the standard of care. Ironically, it was after gutta percha. So we went from gutta percha to silver points, and we realized that silver points leak and they're really not good over a period of time. And so now we're back to where gutta percha again. So it's kind of really funny how the circle of life kind of just repeats itself there. So we're a little concerned about this case. You know, we got some leakage here, no permanent restoration, and we have a large periapical lesion here on the distal root. So what would you do? Doc, what would you do? This jumped in your Friday afternoon, patient comes and they present. What would you do? Would you tell them to extract a tooth? What about an implant? Would you retreat it yourself? Would you refer it to an oral surgeon, possible Apical? Would you place the patient on antibiotics and tell them, hey, you know what, it'll probably get better? Believe it or not, I still have dentists that if they see an area of infection in the tooth on an x-ray, they just give them antibiotics and they don't give them any follow-up. People, antibiotics is not going to cure the problem. What it does, it acts like a band-aid, or kind of like a bucket to a broken pipe. It basically doesn't fix the problem. It keeps it from getting worse for a period of time. By the end of the day, you have to go in there and get to the root of the problem. No pun intended. And you have to figure out where the source is and remove it in order for patients to heal. So let's jump into this. So let's take it a little further. This was not just an ordinary patient. What if this was your family? Your mom, your dad, your sister, your brother, your child. Let's bring it on home. What if it was you? What would you want? What would you do? The wise clinician, in my opinion, will refer to the endodontist for evaluation and possible treatment. So the patient was sent to me. So we talked to the patient, and we didn't promise them that we would be able to save the tooth. We told them that, hey, you know what, this is a situation, the prognosis is guarded, but if you're interested in trying to save the tooth, we recommend the retreatment because it's going to give you the highest success rate versus surgery on the tooth or taking the tooth out or what have you. But he said he didn't want to lose the tooth. So we jumped in there and we disassembled it. We actually used micro forceps and microscopes to take these silver points out. And we actually placed calcium hydroxide, and you can kind of see from this x-ray how large that lesion is. We removed the silver points. You see, we got 1, 2, 3, 4 silver points, and we obturated it. And the obturation looked pretty good. We put temporary filling there. We were able to get the patient back in 4 years. They got a crown, they got their restored, and really nice healing. Really nice healing there. And that patient was ecstatic. They were happy they were able to save the tooth. They were happy that their general dentist was smart enough or wise enough to send them to the endodontist. So as a dentist, all of us, no matter your specialist, general dentist, what is our most important goal for the patient? In my opinion, the most important goal for the patient is maintaining the health and integrity of our patient's natural dentition. That's the #1 goal. What is the dental profession's responsibility? Well, let's take a look at some things. Doctor is from the Latin docere, meaning to teach. Also to provide the public with the knowledge to understand the nature of their disease. Also to help our patients decide the treatment options best suited for their dental health. I can't begin to tell you how many referring doctors from all over the world send me an x-ray, say, hey doctor, can you diagnose this? So yes and no. I can give you a partial diagnosis. We can't give you full diagnosis because guess what? The patient isn't in my office. Now with this type of communication here, there may be one day a time where you can actually take the camera to the office and I can actually virtually help diagnose the case for the patient and the doctor. Without me actually physically seeing the patient, just on an x-ray alone, you can't get the full diagnosis. An accurate diagnosis is the key when you're talking about taking care of patients' issues, especially with root canals. So like I mentioned before, radiographs alone do not provide enough information to make the correct diagnosis. And we still, as endodontists, and you should too as general dentists, should always use the periodontal probe and all necessary endodontic diagnostic tests in a clinical assessment before recommending any treatment. Even though we're not doing perio, we still got to probe every tooth that's in question for endo. Why? I'll talk to you about that a little later. Let's look at how do we do this. What kind of things do we use to check for that? We use pulpal and periodontal testing, tools and techniques. Let's go to some of those things. Cold, which is my favorite, endo ice. To get a pulpal diagnosis, cold, it works very, very well. If I can't get a good diagnosis with cold, then we may use some heat. You can use gutta percha, heat it up. You can use warm water baths. Electric pulp testing, these are for some of those calcified cases, older patient, don't have really any temperature sensitivity, and you get some mixed results with the cold and heat. You can use the electric pulp tester. However, you can't use the electric pulp tester through a crown, unfortunately. What about some of the periodontal testing? You can use percussion testing. I use the back of a mirror, the tap. You can use palpation, and also you can use biting. We use a bite stick or a tooth sleuth to check for cracks. And this right here, patient came to my office with some teeth and some saliva. Told me to bring, can I put the teeth back? Asked him how long they were knocked out. He said about 2 days. So trying to put these back is probably not going to happen. In fact, it didn't happen. Let's talk about evidence-based dentistry. This is a hot topic, and it should be, because we should be given dentistry based on research evidence, not just what we feel, not with what our mentor taught us. We should be doing dentistry based on bona fide research, evidence-based dentistry. Basically, dentists should arm themselves with the best available scientific evidence with regards to treatment prognosis. Treatment options should be grounded in science rather than popularity or hype. In fact, recently there has been a big discussion with the popular doctor that has his own television show about arsenic in apple juice. And when they basically looked through this, and they found out he didn't have enough adequate evidence-based research for him to really make that statement. And it created a big scare and havoc throughout the community. And unfortunately, they're going to be doing some more in-depth non-biased research just to make sure that this thing is inaccurate. And we've seen things like that in dentistry as well, with the mercury scare and amalgam, so on and so forth. So we really have to get to the evidence-based and some bona fide non-biased research when we look at how we're going to treat these patients. This is an example of a very great, very good refereed article or research by the Journal of Endodontics. And this research talked about endodontic treatment outcomes in a large patient population in the USA, an epidemiological study. And basically, it goes into a lot of different information, but at the end of the day, it talks about the retention rate of root canal treated teeth. It says overall, basically 97% of teeth were retained in the oral cavity after 8 years after initial non-surgical endodontic treatment. 97%. That's great. That's a really good success rate or retention rate for these endodontically treated teeth. So Dr. Robert Salabrini and Ellen Rothstein, you can actually pull this journal up in the Journal of Endodontics. And you also can Google this if you want to know more information about their research with this particular article. In general, the results from the study, over 1.4 million teeth treated. 97% of teeth were retained in the mouth 8 years after the initial root canal treatment. And this wasn't just with specialists. This is with general dentists, so on and so forth. May even included some dental students, I'm not sure. But at the end of the day, the 97% of teeth were retained in the mouth after 8 years after initial root canal treatment. Teeth were treated by general dentists and endodontists as well, like I previously mentioned. Retreatment, apical surgeries, and extractions are only 3%. Only 3%. 85% of extracted teeth did not have full corona coverage. So 85% of those ones probably end up cracking because they didn't have a crown, or they leaked because they didn't have adequate restorative material. This is another thing that I've heard out, and you've probably heard this as well, that implants are more successful than root canals. So when I hear that, I want to go and look at some non-biased research and see how accurate that is. So let's talk about that. So this was a study that I was able to locate here. Basically talked about the retrospective cross-sectional comparison of initial non-surgical endodontic treatment and single tooth implants. And basically they said the failure rate was the same. So in other words, initial root canal treatment done compared to a single tooth implant, the success rate is about the same. The main difference though with implants, they had more managing issues with screw abutment loosening, things like that. So the next time you have a patient that come into your office, you make sure you tell them that the success rate for initial root canal treatment and a single tooth implant is virtually the same. So these are some results from that study. 196 matched implant and root canal cases. Restored endodontically treated teeth and implant restored teeth, like I mentioned before, have approximately the same success rate. However, there are more post-op complications with implants than endodontically treated teeth. And this is a case which someone did the implant and they did not line it up. So this patient was having some issues, and she said that something kind of felt like it was rubbing against her gum. And I actually told her she probably need to go back to the person who performed that implant to get them to reevaluate it. What's wrong with this case? Look at this upper premolar here. It's upper second premolar. What do you think is wrong in this case? And we'll take a look at this. This is the same one, radiographic. I'm going to give you just a second to look at that and think about that. I know you guys probably already know the answer, but let me help you. This crown was actually seated backwards. This is actually the buccal aspect. This is the lingual aspect, and it's high in this spot right here. So that's why the patient kept saying, yeah, it feels like I'm keep touching it with my tongue. So that's one issue. So I'm not sure if the assistant seated this crown or the dentist seated this crown. But again, I asked her to go back to see her dentist to get it reevaluated. But she had another issue as far as going on here. They actually missed the canal. So not only she had her crown cemented backwards, he also missed the canal in this case. So she actually scheduled to get the root canal retreated, and then going to have to get that crown re-evaluated and taken care of. So it's very important to stay current in endodontics. Things change so fast, just like with technology and endo. But is it quality change, or is it sales pitch change? So we're going to talk about that. Materials do change. I mentioned before, at one point there were silver points versus gutta percha. Now you got carrier-based filling materials, and now you have the advent of resins, Resolons, and things like that. Also, you have something new that's coming through the pipeline called gutta core, which is basically gutta percha wrapped around another dense version of gutta percha, similar to a thermofill. Instead of having the plastic carrier, it's a gutta percha core carrier. So things do change. Techniques change, lateral versus warm vertical. And with some of the resins, they say that you don't even have to condense those. You use a resin sealer and a resin-based cone, single cone, you sear it off, you're done. Medications change from formal cresol to calcium hydroxide, which is still a little debate of should we even still be using formal cresol in patients versus the advent of calcium hydroxide. Equipment change, loops versus microscopes. Most endodontists, if they're current, they have microscopes and use microscopes. Treatment modalities change as well, especially with trauma cases. There are some cases now that they say you don't want to treat long-term with calcium hydroxide because it can break the tooth down. And at one point, we were treating long-term with calcium hydroxide. So, are you ready? Doctor, are you current? Are you equipped to handle these challenges that's going to come through the pipeline and also using these new materials? You got to be careful because some of these dental companies and consultants, they try to sell you, I call them pipe dreams, buy, sell, kind of like you're on the floor at the New York Stock Exchange. Hey doc, I have a technique, you can do this molar endo in under 30 minutes. Under 30 minutes, no problem. One file can do the whole treatment. We have one file, it can do the whole treatment. Be very careful. Faster is better, doc. We can get you doing these root canals so fast, they'll be better and you'll be more productive, you'll make more money, and you can retire at age 35. Do it like the endodontist in our 2-day seminar. We're going to get a general dentist to teach you how to do it just like an endodontist in a 2-day seminar. Be very careful and don't be deceived by some of this stuff on out here. Oh yes, doc, it's a recession. Keep the money in your practice. Don't send to the endodontist. Just do it yourself. Like I said, don't monkey around with these dental companies. Get the facts. You can call me, and I gave you my information. You can call your local endodontist, and you ask them about some of the current techniques and medications and equipment, and see what they're doing and how well these things are being promoted, and is there a significant advantage in using them. This will save you a lot of time. It'll save you money. And it also increases respect and compliance from your patient. Just imagine you have Miss whoever, one of your best patients, and you have a case you're not really sure about. You send it to an endodontist and she said, I had a great experience. She's going to go out and not only tell people about the endodontist, but she's going to tell them about you. She's going to say you cared more about them to make sure they have a great experience than you trying to do it all yourself. And she's going to tell other people about you and your ethics and your morals. And she's going to be happy, and she won't be afraid of root canals. So these are the kind of things I just want to just, impart upon you that, sometimes when you're not sure or you have a difficult case, send to the endodontist. I'm actually in the state of Georgia, and I actually pulled some records from a couple of years ago about some of the malpractice claims, and this is just only a few. In 2008, a root canal poorly performed, which led to extraction and nerve damage. It cost the dentist $239,000. 2005, there was a broken drill in the root canal, and it cost the dentist $76,000. In 2004, a failed root canal leading to significant face disfigurement due to leaked solution cost the dentist $46,000. Not only money, reputation. And your reputation, sometimes that's all you have. I'm an expert consultant to the Georgia Board of Dentistry, and these are some of the things that I see that comes across my table, or I have to consult with some of my referring doctors. Dentists did not have a proper consult to the endodontist for complex cases. Root canal treatment was not performed within the standard of care, which we discussed earlier in the presentation. The chart was not properly documented. You can't not write enough. The more you write in that chart, the better off you'll be if you have to face the board. So you want to make sure you get all the information, detailed information as you can. Just in case there's an issue or goes to litigation, you have a lot of information you can stand on. Informed consent was not signed. I can't tell you how many times that I've seen that patients hurting, you just want to hurry up and get them back, and you forget to get them to sign informed consent. They have a problem. They go to the board, go to their attorney, and they lie or say, well, I didn't know what he was doing. I thought he was cleaning my teeth. And you know that you went for a root canal. But if you don't get them to sign an informed consent, you know, you're going to be in trouble. This is the most common issue that I see. No rubber dam used. This is the universal standard of care. No matter what state, city you're in, you have to use the rubber dam. So this is the standard of care with 4 stars by it. So you have to use a rubber dam. If you can't use a rubber dam, you should not be doing root canal. You say, well, what's the big deal with the rubber dam? Some people say, was it just isolation? That is a part of it, because if you are taking bacteria and things out of the tooth, you don't want to let it bathe in saliva where the original source of the bacteria was in the beginning. So you definitely want to use a rubber dam to isolate the tooth. Not only that, you want to use it for patient safety. What you don't want to have is a patient to aspirate a file, not swallow it, because they can pass it through the restroom, but aspirate it, it goes into their lungs, has bacteria on it, and then you have to open them up. They have to go to emergency surgery, get their chest opened up to remove that that file or what have you, and there are going to be some consequences as a result of that. So if nothing else, most patients will ask is, can I save my natural tooth? 9 out of 10 people prefer to save their natural tooth if possible from a nationwide poll. 9 out of 10 people, especially that front tooth. The value of retaining the natural dentition. Continued proper reception due to maintaining a healthy PDL, periodontal ligament. So basically, when the patient be able to chew, they can feel like it's their own tooth. Normal physiologic movements during functions. The patient still can have orthodontics on the tooth where they can't with an implant. Arch hard and soft tissue continuity. And the ability to withstand the normal forces of mastication. One of the main reasons why root canals fail is traumatic occlusion. So they don't have a ligament to absorb some of that pressure. So with your natural tooth, you can have that ligament, and after root canal, even after root canal, you can have that normal biologic movement with that. What are some of the current endodontic treatment? We now can achieve new levels of success and predictability with our treatment. We're creating treatment options not available to the public in years, and we're going to be talking about that, especially some of our material called MTA. And also patients are very happy about that. They're able to save these teeth that otherwise would have to be extracted. And even if it was they had the issue 20 years ago, a lot of these teeth would have to be extracted. So we're going to show you some of these cases. What are some of the new treatment paradigms or paradigm shifts that we've seen in the past 10, 15 years or so? New nickel titanium instrumentation. Now they even have M-wire. At one point the hand files were stainless steel files, but now we have these nickel titanium files that actually can bend and curve and get in some of the most torturous canal anatomy that you wouldn't ever be able to get into with with hand files. And also it makes it more efficient as well. We incorporated microscopes and microsurgical instruments, especially with retreatments. We have new generation of more accurate apex locators that help us be able to determine where the physiological apex is versus just the radiographical apex. We have digital radiography that allows us to see a lot more things that we normally couldn't see. Also, which is not in the slide, we have the new advent of cone beam technology, almost kind of like the CTs that physicians take, and we can actually get a 3-dimensional image of what's going on in the tooth. And also we have recently developed endodontic materials that we'll talk briefly about that. So here's a collage of some of the things that we're using now. Everything from digital radiography to different types of nickel titanium files, System B, obturas, rotary instruments, apex locators, all those things. Microscopes here, we use this MTA, showing that MTA it has multifactorial usability, and we're going to be talking about a few of those coming up. Microscopic endodontics. In my area at Nova Dental, Nova Southeastern University Dental School, I was one of the first ones to use the microscope, and they captured a picture and published it in the local magazine. And I still use the microscope on every single case. In my opinion, you can't treat what you can't see. So microscopes actually can give us up to 20 times magnification. Here's a case, tooth number 19. We have a lesion here in the furcation, deep restoration, and the lesion actually probed here. And you can see here a trace to gutta percha right here. The dentist wanted to remove the tooth. The periodontist wanted to remove the tooth. They said that, hey, you know what? Even if you can save this tooth, this is going to be a plaque trap. The patient's still going to be able to lose the tooth. The patient didn't want to lose the tooth. So once we opened the tooth up, we did the endo, and they did have a perforated defect here on this distal root towards the mesial aspect. So what we did, this whole canal, instead of filling it with gutta percha, we filled it with MTA, which is mineral trioxide aggregate, which we call it our miracle material for endodontists. And when we placed the MTA in, we told the patient to come back in about 6 months or a year so we can monitor it and see if it's going to heal. So we brought the patient back in 6 months, and look at that healing. That is tremendous healing. If this was 20 years ago, this tooth would have been taken out. And we call that endo magic. Well, not really. MTA. And also with using the current techniques and things that are available to us as endodontists, we're able to do these kind of cases routinely. What about some of the treatment options we have? The patient has, initial non-surgical root canal treatment, non-surgical retreatment, surgery. Sometimes surgery is necessary. Periodicular surgery, perforation repairs, root or tooth resections, and also root submergence. Especially if you have a patient that's on bisphosphonates, even though you can't restore the tooth, sometimes it may be necessary to do the endo, put a healing cap, or put some type of restorative material on top of it, and also help that tooth, will keep the tooth in the bone, because if you remove the tooth, patients on bisphosphonates, you can create some necrosis there with the bone, and we can put the patient in a more medically jeopardized condition. We can do procedures called Apexification. This patient had a trauma when they were young. The root never closed up. So we went in there, cleaned it out, put an antibiotic in there, calcium hydroxide. We let it stay in there for a few months, 6 months. And this is a traditional way of Apexification. Formed a hard tissue barrier, and then we actually obturated it with gutta percha. Patient came back 2 years, said that everything was feeling fine. Apexigenesis, you have a live canal, live nerve, and the apex is open. So in these cases, we take advantage of the vitality. So we basically do what we call an MTA pulpotomy. Again, this is another use of MTA. We clean the top part of the nerve out, we place the MTA right along the floor, and we restore the tooth. So we brought the patient back in a year, 2 years. You can see here the apex is closing. The mesial root is a little slower to close, but you can see that distal root, how the closure on that looks great. Patient asymptomatic, and also the tooth is still vital to pulp testing. So let's talk about some of the success rates. Orthograde endodontic treatment runs about 90–95%. Retreatments, 80 to 93%. Surgery, 40 to 78%. Root canal therapy on number 14 and 15 is a pre-op radiograph here. 14 and 15, we see recurrent decay. Number 14, and we did the endo. Post-op radiograph. Root canal looked pretty good in this angle. Let's take another angle and see what it looks like. Wow, 1, 2, 3 canals, separate apexes in the mesial root of that number 14, 4, 5 canals here, and number 15, 1, 2, 3, 4 canals in number 15. So without microscopes, there's no way I would have found all those other canals there. More interesting anatomy we have here. Got this lower molar here, and radix intermolaris is an anatomical term where you can have another distal root hanging off of that lower molar. So look at this anatomy here, and we take another view. So thanks to microscopes and nickel titanium files, we can treat these cases with a relatively high success rate. Let's talk a little bit about apical surgery. This is me actually in Mexico. We went and did like a mission trip type of thing. This is one of my professors here. And we went to Mexico to do surgery and also teach the dental students how we do surgery in the United States as far as keeping the tooth. So this is one case I'm going to share with you. Surgery number 21, tooth with a history of a root canal and a previous apicectomy. The tooth remains symptomatic with drainage and severe bone loss. There was a third foramen located. The foramens were retrofilled with super EBA, and the area was grafted with DFBBA, which is demineralized freeze-dried bone, and a membrane. So let's take a look at the surgery. So here is this premolar here from a pre-op, large area of infection here. So the endo was done and also an apical. The area did not heal, so we flapped it back and we used ultrasonic tips. We're able to find additional canals here, and we're retro-prepping the tip there. And look at this, an additional foramen here. There's no way you're gonna predictably go in through the top and get 1, 2, 3 foramen here. Let's go to the next slide. So here we place our bone here over the defect and our grafting material. A few sutures there. And you can see 3 portals of exit, 1, 2, 3, all retrofilled with super EVA, sorry. This is another angle of that. So we do have to do surgery sometimes, but you know, apical surgery is not as common anymore due to the higher success rates of retreatment. Me personally, I maybe do 2 or 3 surgeries a year because the success rate on retreatments are so high. And typically, if you retreat properly, if it doesn't heal, usually the root has a crack in it somewhere, and surgery in most instances won't help the case as well. Why do some good-looking endodontic treatments fail? One main reason endodontic treatment failed is due to coronal leakage. And basically that means that the restoration is not adequately sealing off leakage, and bacteria can get in there and create problems with the previous root canal. So let's talk a little bit about that. Here's some facts on leakage. Root-filled teeth without coronal restorations had bacterial products at the apex after only 3 weeks. That's by Torbenajad, JOE 1990. After 3 days of exposure to artificial saliva, leakage in canal spaces were already apparent, and Madison showed that in JOE in 1987. What's the influence of coronal leakage? Depends on the amount of leakage, depends on the presence or absence of coronal restorations, the time of bacterial challenge, the quality of the root canal filling material, and also the number and virulence of leaking microorganisms. And high quality restoration plus a high quality root canal filling is equal to less coronal leakage, which also equals to a high success rate. Everybody's happy. So at the end of the day, it's really a continuum. Me as an endodontist, I can do my best job as a root canal specialist, but the best job is also determined on how well you restore the tooth, how fast that patient get back to your office to get that tooth restored. So my success, the root canal success, is also based on the ability for you to be able to do a very efficient, a very, very, very good restoration. The success rate of endodontic treatment without periapical pathology exceeds 95% of cases, despite the fact that most coronal restorations leak. And that was proven by Sjogren and Goldman in 1992. Inadequate cleaning and shaping the canals will also lead to failure because of some of the techniques that's taught. There are some techniques, if it's not taught properly, if it's not cleaned and shaped, the canal will fail. It will look great on the x-ray, especially with thermofills. They look great, but usually it's because it's not adequately cleaned and shaped. And that's what we talked about with carrier-based obturators especially, and thermofills. I retreat more thermofills than just about anything else. Cases look great on the x-ray, but when we pull the thermofills out, we look in there, there's still tissue and bacteria around there that was not cleaned out properly. So this is a case of a thermofill retreatment. The root canal actually looks really good radiographically. It got all the way down, got an even little puff there in that area. The patient was hurting and pain, so we went back, we took it apart, put calcium hydroxide in there, retreated it, and the area, we got a patient back in a year, and that area healed up very well. So root canal treatment and retreatment really does work. Let's look at some of the past assessment of past success failure studies. And in endodontics, it's kind of different because you have multiple variables regarding that. So let's look at some of these things. Studies have erroneously included failures due to periodontal disease. The patient had periodontal disease, then the endodontic treatment got the blame for why the tooth had to come out. Root fractures. Again, you can have fractures in the root before the root canal even gets started. There are some fractures we can't even see, and they blame because of the root canal, and the issue wasn't the root canal wasn't done properly. The tooth had a root fracture. Inappropriate restorations. You can, like I said before, you can have to do the best root canal, but if the restoration is leaking, cracked, or so on, and then it's going to cause the tooth to fail. And also the presence of coronal leakage. These, as I repeat, these are not endodontic failures, but weak links that contribute to the failure. Let's talk about the endodontic restorative continuum. People like to do endo versus implants. One of the reasons because it minimizes the time spent in treatment, and also it also presents a cost-effective approach to optimal treatment versus implants. So getting the root canal is cheaper than getting an implant and the crown on top as well. However, like I mentioned before, there are some obstacles to successful endodontic treatment: severe periodontal disease, teeth with suspected fractures or cracks, inability to repair or salvage roots or teeth with iatrogenic defects, inability to use a particular tooth or teeth as an abutment or fixed or removable prosthesis, even if it's treated endodontically. These are some treatment options when a tooth cannot be retained. They can use a bridge, a removable partial. They can use implant supported prosthesis. They can be replaced by even transplanting. We don't hear a lot about that. Transplanting a non-functional impacted third molar into the site where you're going to remove the tooth. So let's look at the big world of implants. Who's best for the job? Is it the periodontist? Is it the oral surgeon? Is it the general dentist, the general practitioner? Is it the prosthodontist, or is it the endodontist? Did you know most manufacturers companies, they really don't care, because they're going to sell the product. And at the end of the day, that's what it's the bottom line for them. It's about selling the product and making a profit. So you got to be very careful. You know, the question is, will implants one day become a specialty within dentistry? Currently it's not. But, you know, hey, depends on the demand. It may actually one day become a specialty. However, you do have some potential implant complications. You got hemorrhage secondary to surgery. You can have neurosensory disturbances, soft tissue problems, fenestrations, dehiscence, sinus tracts. Do you know how to treat them? And if you don't, you're going to really be behind the 8 ball here. especially as a general dentist. Here are some other potential implant complications. Mechanical complications including prosthesis screw loosening, abutment screw loosening, prosthesis screw fractures, implant fractures, implant loss in smokers, implant loss in type 4 bone found in the posterior maxilla. Who's held accountable if an implant fails? The person who did it. And do you know how to properly manage the failing case? And who are you going to refer the case to if it fails? And the history of bisphosphonates now, we found out that can affect implant surgery and also osseointegration. Most implants require an extended treatment protocol and employ the use of provisional restorations while waiting for osseous integration. However, there are some immediate loading implants, I understand, but most of them you have to wait for the implant to osseointegrate. Currently, there's no consensus that exists on what constitutes implant survival versus true success, because comparing an implant to a normal tooth is kind of like comparing apples to oranges, because an implant doesn't have the ligament that a natural tooth has, so it's very hard to compare true survival versus true success, especially from a histological standpoint. But both procedures, depending on case selection, which is key, and appropriate consultations, will ultimately result in a high success rate and happy patients. So, the best treatment option should depend on what is best for our patients, not our pockets. So, if this was you, and if you looked in the mirror, if you were the patient, what would you want? And that's what you have to ask yourself. Every patient you see, you ask yourself, if this was me, what would I want? And if you can answer that question in your heart very honestly, and then typically chances are you're making the right decision. Whether you decide to extract the tooth or refer the patient to an endodontist to get another opinion on the tooth. Natural teeth. As dentists, that's what our main goal is to save the patient's natural teeth and keep them in the most optimum oral health condition. Endodontics. Primary treatment of choice when the dental pulp is compromised. And also is the primary treatment option when the removal of the dental pulp would facilitate a reconstructive treatment, whether that's a crown, whether that's a bridge, or so on and so forth. Thank you for your time. If you have any questions, you can email me again at dr.short@yahoo.com. Visit our website at